Alrighty, welcome members. We are just waiting for a few more people to jump in. I can see everyone filing in. Pop below in the chat if you're in there. For those that know how to pop in there before. I'll just give it a few more seconds while we wait for some more people to jump in. There is a new little feature for today, guys, as well. For those that have come before, you can pop a reaction in there, a little wave or a love heart or party emoji if you want to jump anything in there from anything from the session today. But with me, we've got Merrin Martin from Active Rehab Solutions that will be taking you guys through another skill session today. For anyone that's new and that doesn't know how the webinar works, pretty much if you have any questions of the session throughout or for Merrin, just pop them in the Q&A box rather than the chat, and Merrin will get to them all at the end with myself after she's gone through her presentation. With the CC as well, there'll be a short survey that pops up after the webinar today. So just jump through and complete that and you'll get your CC added automatically tomorrow or on Friday at some point as well. But Merrin, whenever you're ready, good to get going.
Okie dokie. Thank you so much for that introduction, Luke. That's wonderful. I'm very excited to be here with you guys today to talk more about the knee and in particular about patellofemoral pain. So I'll just start our little lecture that I've got going for you here. And then you can follow along with all the PowerPoint slide that I've prepared for you. And it should take about an hour to get through everything, but I'm really enjoying this new technology and the new ability to be able to get our all our work that we've done out and across to everybody all over Australia. It's actually just such a wonderful platform to be able to work on. Over the COVID excitement, we've had the last 2 years of doing 3-day Zoom workshops online for everybody, in particular ESSA people and fitness or Oz active people or Pilates instructors. So it's been fabulous to be able to use this way of communicating rather than face-to-face. But this year we're back face-to-face, so I'm very excited about that. Now, just to get started while everybody's still joining on, I'll just introduce myself a little bit more and just talk about our my company a little bit more. And basically, my name is Merrin Martin. I am have been in the industry, in the fitness industry since the 80s. So I have seen many different fashions and fads that have gone through the fitness industry over the years. So it's been fabulous to be involved in health and fitness for that long. I started off as a group exercise instructor and was a group exercise instructor for many years when it used to be called aerobics with the leg warmers and the G-string leotard. So that's an exciting visual for you all online. And then from there have gone into more corporate fitness and, going through a sports science degree and a physiotherapy degree and doing a lot of past 20 plus years of clinical Pilates instructing as well. So I have kind of put everything together into these workshops from all sort of walks of life, from, intensive care through to, elite athletes, and come up with with my sort of version of the rehabilitation or prevention of injuries so that we can keep all our clients exercising, which is the main thing in life. So just a little bit about me. Here's my lovely little family. All of them have got COVID at the moment, so I don't know how the hell I've dodged it, but that's the way life goes. I'd like to do netball coaching. I've been involved with netball a lot, so love team sports, but I also do, like I say, a lot of Pilates and I've got a personal trainer that I see as well, so it's kind of a good mix of everything in there. As you can see, I've been working in the industry since the 80s and since I left school. And basically I've gone through all different types of, experience. And I think that's one thing, is that knowledge is just so important, and I've never stopped trying to learn. I've actually got a webinar that I'm attending tonight from the physio group of people on musculoskeletal injuries. So it's always good to just, be around knowledge as much as you can so that you can just keep on learning, because things change all the time. Just a little bit about our Active Rehab Solutions company. So we have been delivering workshops for personal trainers and for exercise physiologists for the past 16 years. The workshops have evolved massively every single year. We have face-to-face workshops, we have online workshops, and we have Zoom workshops over the last couple of years, which have been fantastic. And we also have, you know, every year we have multiple people contact us to do their own staff training. So it's fabulous to be able to have that ability to go in with a small group and do the education for that staff training. That's something that I'm very passionate about. And with, you know, with what Active Rehab Solutions is all about, just to give you an idea of what we're focusing on today, is all about the knee and knee stability, and in particular, just the part of on patellofemoral pain today. So this little tiny lecture is a 1-hour snippet out of all of these courses that we hold, the workshops that we hold for health professionals. And the key concepts that we keep going through with rehab is that you cannot actually rehab somebody by only focusing on that one body part. It is a system of body parts that need to be integrated together. So, you know, from patellofemoral pain, low knee pain, a very common knee pain that people get, you can't just do knee strengthening. You must do your core work, your posture work, your hip stability work, your glute strengthening, ankle flexibility. You know, there's a whole pile of things where your whole body needs to be addressed to be able to have successful prevention or successful, rehabilitation for your clients that have a bit of knee pain. So just to remember that, that's why I've got that little system, that the whole body is integrated and they all affect each other. And how we run our workshops, this is what we're going to do today, is give you a tiny little snippet of what we do. And the first thing is we give you a little bit of a brief anatomy revision about a particular injury or a dysfunction in the body. So just a little heads up, a little bit of anatomy, a little bit of learning as to, what it is the injury is going to affect. It's always good to go over anatomy. The more times you go over anatomy, the better, because you always learn something new. And then the second thing we're going to go through, which is relevant to some of you, maybe not relevant to all of you, especially the group exercise people, is how to do a small assessment in relation to that particular problem. So we'll have a look at a couple of things today on patellofemoral pain. And then finally, which is the most important thing for you guys, is what the hell do I do? What are the strengthening exercises? And what are some of the stretching or release techniques that I can do with my client when they come in so that we can help them keep exercising and get on with their lives and their goals that they want to achieve. So that's kind of how the workshops go. So with our big workshops that we do over 3 days, I literally break it down into sections, anatomy review, have a look at assessments, and then give you those exercises for strengthening and stretching that is required. So here we go. Let's do a little bit of anatomy. With the knee joint, there's a couple of things to remember. Just very quickly, you have patellofemoral joint, which is the patella in that intercondylar groove on top of the femur. So that's why it's called patellofemoral. And so it's looking at how that patella glides and moves in relation to the femur. So that is our main joint that we're going to be focusing on today. So that's something to keep in mind. The sesamoid bone, which is what the patella is called, means that it's a floating bone as such, and it actually is completely surrounded by muscle. It hasn't got ligaments attaching it onto another bone. It is surrounded by muscle, and it is influenced 100% by the quadriceps muscle. So just keep that in mind, because that will come in very handy later on when we're looking at what muscles we can strengthen and how that affects the patellofemoral joint. If you have a look, for example, with the tibiofemoral joint, which is what everybody tends to think about with the knee as the knee joint itself, the knee joint proper, that is where you have the femur sitting on top of the tibial plateau. You have your meniscus that is cushioning that femur. You can see the meniscus there on either side, lateral and medial meniscus. And you will have multiple ligaments that are supporting that knee. So this is where your ACL, your PCL, which is your anterior and posterior cruciate ligaments, as well as your MCL ligament and your LCL ligaments, which are your medial and lateral, collateral ligaments that tend to hold that tibiofemoral or the knee joint in place. So that is not completely reliant upon muscles. It actually has a lot of ligamentous stability there as well. So just something to think about compared with patellofemoral joint, which is completely influenced by the muscles surrounding it. Another joint that's there at the knee, which is a little bit more lateral, so you can feel that on the outside of your shin, I suppose, if you go round to the top part where the fibula head sits, and that is the proximal tibiofibular joint is the name of that joint, and that is looking at how the fibula attaches onto the tibia. So that joint is very much related with the ankle joint. If you think about the fibula coming down, that is your lateral malleolus on the ankle. And when you have ankle sprains, this joint up here, the proximal tib fib joint, as it's known, can become affected and give knee pain. But it's actually not inside the knee, it's a little bit lateral on the outside of the knee there. So it's something just to keep in mind as well. So that's just a bit of anatomy about the bones. Like, let's start deep down and have a look at the bones. The main thing to keep in mind is that patellofemoral joint. That's what we're going to be focusing on today. Okay, looking at the next slide, we'll have a look at the muscles which come in and surround that patellofemoral joint. One of the muscles that's extremely important for stability of the patella and for function of the knee is what's called the vastus medialis oblique. So part of this muscle of the vastus medialis is like a longus, it's called, which is basically the top part of that muscle coming down is known as vastus medialis longus. And then the bottom fibers is called the oblique part, so the vastus medialis oblique. Now, there's a lot of research now that shows that it has a separate nerve supply. It's actually almost like a separate muscle, the way that it functions. And it's very much influenced by neural innovation there in regards to how it behaves when there is pain, when there's swelling, when there's injury, when there's surgeries. You know, there's multiple influences that can have an effect on how this VMO will actually fire up and function. So that's just something to keep in mind there. But we're talking mainly about like a lot of looking at this inside quad muscle here, this VMO quad, and how it works together with the whole quadriceps muscle group, you know, as a whole. Because that's another thing that's come out with the recent research is that you cannot just activate VMO on its own. It's very, very hard to isolate VMO and just do VMO training on its own. It has to be activated in conjunction with the rest of the quadricep muscles working together. And they found that even though the VMO is extremely important for that patellofemoral tracking, overall quadricep strengthening is just as important. So you can't just only isolate that VMO and train it. We need to put a focus on it, but put it into play with the whole of the quadricep muscle. So that's interesting too. All right, so if you're thinking about bony alignment and some of the muscles, you'll be thinking about leg alignment. I mean, that's a massive thing that we talk about and that I hear all the time in group exercise classes and personal training sessions is keeping your knees over the toes, you know, don't have the valgus knee drop, stop rolling through the ankles, you know, lots of talk about keeping your body in a certain position or alignment whilst you're training it under load. And, you know, what I found in regards to posture with the alignment from the perfect optimal posture that you can get with clients is to have the middle of the axis of the hip joint, the middle of the axis of the knee joint, and then the ankle joint, the middle of the axis of the ankle joint to be aligned as much as you can, which basically means hip, knee, and second toe, I always say, in a line as much as humanly possible. Now, there are postural influences on people being able to keep that alignment, and they're the ones that you can actually address, because it's usually a muscular weakness or a postural problem that's causing it, which is good news because you guys can fix it. There could be, though, a structural problem, so which I'll show you in a sec, some examples of like knock knees or tibia vera, like the bow leg type of posture. You can't change that bony alignment. You can support it as much as possible, but you can't change it. So it's good to kind of know whether your person in front of you has a structural problem that you can't fix, or a postural problem that you can help them improve by working on their strengthening and working on their flexibility. So I'll talk about that in a second. Now, the other thing is with the optimal leg alignment with hip, knee, second toe, if you tell your clients to keep your knee over your first toe, if you keep the knee over your toes sort of thing, they will bring their knees inwards to go over the first toe, which usually causes them to be a bit more valgus or a little bit more knock-kneed. If you tell someone to keep their knees over their second toes, they actually activate their glute muscles a little bit. They kind of lift their arches a little bit, and they bring their knees out towards their second toe a little bit more. So it's kind of like a little cheat way of getting them to activate those postural stabilizers to help support that knee alignment when you're doing things like, your squats, your lunges, any sort of jumping or traveling type movements. You want to bring this cue into play. Okay. So yeah, what I was talking about posturally, you can see on people when they're in front of you and they're doing a walk. Like let's look at this picture here of the little girl walking up and down the hallway in my clinic that we own, and you can see that every time she's weight bearing through this leg, the knee is pointing inwards. Can you see how the knee's right in there? The toes are actually pointing right inwards. And you can see that this, if you do a line across the top of her pelvis, the swing leg has dropped down. You look at the line of the shirt there, that this leg has dropped down and this one is sinking out to the side. So you've got like a lateral pelvic shift every time she takes a step. You can see that there's no glute activation, glute medius activation going on here, and it's causing her to be internally rotated through the hip joint, which causes the knee to go in, which causes the toe to go in. So you can see how it kind of sets up this sort of cascade of leg alignment events every single time she stands on that leg. So with her, she was tripping over and falling every time she would go for a walk, or she was feeling like she was really clumsy and wasn't keeping up with people when she was doing her physical activity. And we did a program for her on strengthening through the pelvic stabilizers, like your glute medius, glute maximus, core, doing a lot of quads, making sure ankle dorsiflexors were stretched as well. So, Achilles flexibility, doing lots of stretches there. And the combination of sort of bringing it all in together actually changed her leg alignment. So when she did, we reassessed her after 6 months of strengthening, and it was so much better. So this is like a postural issue that can lead to patellofemoral pain and lead to problematic sort of leg alignments that can be fixed. So this is just one of those examples. Another one is the valgus knee drop. Now, a lot of the time you will see people in their lunging or squatting or even single leg squats that they're doing, pistol squats or TRX work, where they're pronating through their ankle. So you see the ankle sort of rolling inwards. You can see her tibialis anterior tendon. They're working very hard to try and stop that pronation or that rolling in of the ankle. If you have a look at the knee, you can see the knee sort of dropping in. That's what is known as valgus knee drop, when the knee comes right in that way and the ankle sort of rolls in at the same time. And you can see, in addition, that her pelvis is shifting out to the side as well. So you've got this leg alignment with the shifty pelvis, the knee coming in, and the ankle doing a bit of pronation or rolling in. Now, again, that is not her structural alignment. That is a postural either habit or a postural problem that she's come across through her training. She hasn't been working on the strength of those muscles enough. And again, which we'll go through how to strengthen it in a sec, but working on her hip stabilizers and pelvic stabilizers, which is all part of that key concepts of rehab that I showed you at the beginning, that's going to stop the valgus knee drop. So again, these knee problems that you can see happening in very common situations that you'll come across with your clients all the time. The thing to remember with the knee is don't just give them knee strengthening exercises. You've got to give them something above, like looking at the pelvis and the hip, and you can strengthen that as much as possible. And then you may need to do something down the bottom with the ankle strengthening as well. And that way we can get the whole body integrated into that patellofemoral rehab or prevention, just making sure that that alignment is kept properly. So one of the ways that I do change or look at the maintaining the alignment or trying to encourage a better alignment is really simply, you can just pop a pillow, a rolled up towel, a little Pilates ball, whatever you have around, to show that client how to maintain that alignment. So whenever you're doing your squats, your lunges, your core work, your walk, whatever you're doing, Pilates, reformer work, you can always put in a little prop in between the knees to help them understand that correct alignment if they're really struggling with the knee valgus or the hips turning in and their legs are all over the place. So that's just one suggestion to do. So that's even something you can do in class. You can get them all to roll up their towels between their knees, put it between their knees and do squats, with focusing on leg alignment, so that it can be brought in to group exercise situation as well, not just personal training. Okay, so this is just an example of some of the structural alignments that, you're not going to be able to change this person's knee by doing exercises. You can support it. You can try and strengthen it as much as problem. This is one of my clients has a leg like this, and we've been working for ages and ages just to continue with strengthening. It's not changing the shape of the leg, it's just supporting that leg as much as possible, and trying to avoid surgery. I think that's a massive thing for every health professional, to be able to keep people away from surgery as much as possible, especially if they can do some exercises for strength and be able to keep independent for as long as possible. So if you have a look at, this is like a genu-valgum, like a knock knee. So that's basically when your knees are together, but you have a massive gap in between your ankles. That's known as genu-valgum, where the knees are coming together, or knock knees, people will call it as well. Feet wide apart, knees close together. You can just get your client to stand with their knees together and see what happens. And that's easy to tell if they've got knock knees. The second thing you could do is, if you say, bring your feet together and there's a big fat gap in between the knees, like this guy, that's known as genu-varum, which is like a bow leg, I suppose you call it. That in itself can, either the valgum or the varum tends to have more problems with patellofemoral pain, which we'll get into in a sec. But I just wanted to show you these different leg alignments, because you can see that the patellas are not going to be sitting square in the center in that intercondylar groove. They're going to be either out to the side slightly or, pulled upwards slightly, or, just not in that perfect position. The other thing that can happen with leg alignment as well is the, bend back knees, or it's called genu-recurvatum, like where you've got people that are hypermobile. So they have quite long ligaments. They have longer than usual ligaments. And you see them on leg press, or when they come up from a squat, and they will push out and sort of jam out their knees really quickly into that hyperextension. that those people tend to hang back in their ligaments. I mean, you can see the amount of sort of pushing backwards that goes on through that knee joint there. And what happens is, well, they're prone to certain other issues, like down in the fat pad area of the knee, but they won't use their quadricep muscles to help to stabilize the knee at all. They just hang back in the ligaments. So you've really got to be careful when you're taking them through, that you control through range. So people can do this in group classes as well, when they're coming up, like a pump class, coming up from a squat or coming up from a lunge. Don't come up too quickly and sort of jam out the knees. You want to have that what's called end range quads control. You still want to work through the range of hyperextension, but you really want to make sure that there is control right through range. And that means you've got to be watching their quadricep muscles, and in particular that vastus medialis oblique muscle. Make sure it's activating, make sure it's working. You can see that muscle switched on, so that they're protecting their knee from strain into hyperextension. So that's something I just wanted to touch on slightly as well. And the last thing too, which is very common, this one I've kept to last because and this is a common one as well, is that people have, their femurs are in quite a good position and their kneecaps are facing forward, or their femurs are slightly internally rotated and their kneecaps are facing forward, and the lower part of their leg is turned outways. So it's called external tibial torsion, where your knees are straight ahead. So if you look in this picture here, you can see the kneecaps are pretty much facing forward. That one's a bit out to the side, but they're pretty much facing forward. And the feet are turned out. So there's a twist through the middle of the knee joint where the tibia is rotated outways, or their femur is slightly internally rotated. So you get this twisting action that happens just over a long period of time. It can be through numerous different reasons, but people can present with feet turned out and knees staying straight ahead. If you tell them to get their feet into parallel, so like in this second picture here, the feet are in parallel, you'll notice that their kneecaps will be facing in towards each other. So this is another structural problem whereby it's happened over a period of time where people have slowly pushed that tibia outwards. And it's very difficult to get that hip, knee, second toe, leg alignment working in these people. You just have to do your best at trying to, have a minimum, a little bit of parallel, but a little bit of turnout as well. And then you need to make sure that their quadricep muscles, and in particular the VMO and their pelvic stabilizers and glute muscles, are getting strengthened to try and control the amount of twist that goes through the knee. If anything, the focus should be stopping the progression rather than trying to fix what is now a structural problem, okay? So you can still work with them, just don't promise the world, just don't promise the world with fixing that. But it's interesting, you're going to notice, and you probably have noticed, all these types of variations of leg alignment in every class that you do, every small group that you come across. There's all sorts of variations. Okay, so speaking more now that we've sort of gone through the joints, we've gone through like a little bit about the muscles and a little bit about variations of how the bodies present to you in your exercise class. Some of the things to remember, a bit more specific now about what is patellofemoral pain and the reasons that it happens, and then how to fix it. Okay, so that's what we're up to, is the reasons why it happens and how to fix it stage. And if you have a look on this slide here, the top few here are the classics of nearly, I would say about 90% of people have some form of one of these risk factors of patellofemoral pain. So if you have a look at number one, poor control of hip rotation. Classic. So people do not do any like sumo squat positions into external rotation. So many times people are exercising in parallel. They're doing bike riding, they're going for walks, they're doing everything parallel, and they're not doing a lot of stuff into external rotation, which activates those hip rotators. So to control the internal rotation of the knee, you need to be doing some sort of external rotation strengthening. Now, this is a prevention, prevention or rehabilitation to me are exactly the same. You either prevent them from getting an injury or you can rehab them after the fact, either way. For me, I always want people to have strong external hip rotators because that is the number one thing that can lead to patellofemoral pain, one of the reasons. The next cause is excessive pronation. So if you see somebody with their ankle rolling in when they're doing single leg work, stairs, lunges, anything where you've got one-legged work and you see that ankle wanting to roll in, that's what pronation is. Again, we need to address the antepronator muscles, which are the muscles that go around the ankle joint, tibialis anterior, tibialis posterior, perineal muscles, calf muscles, all those muscles that support around the ankle. They are also a huge part of preventing and rehabilitating patellofemoral pain, okay? So just to remember, you can work above and below that issue. It's very important. The other things are femoral anteversion and tibial torsion, which is more the structural alignment that we just talked about with the femurs coming in and the tibias going out. Very hard to change that, but you want to just try and support it as much as possible. And the other top one, top four there across the top of your page, are tight iliotibial band. And that's not just the ITB, it is tight, like all the lateral structures. Think lateral structures are tight. So that's TFL, which is your tensor fasciae lata muscle on the top going into your ITB. That's the one you can actually have it address and have a big effect on to try and reduce that patellofemoral pain from happening in the first place. And also vastus lateralis, the lateral quad muscle, and also bicep femoris, your lateral hamstring muscle. The whole lot can be quite tight. If someone's got their toes pointing outwards in tibial torsion going outways, you're going to end up with a tight biceps femoris, a tight vastus lateralis. Like the whole lateral structure can actually be addressed in regards to helping prevent people with, getting the patellofemoral pain in the first place. So let's just think about those. Those top four are the things that you guys as fitness professionals can actually address in your sessions, whether it be a personal training session or whether it be a group exercise class. You can always include, hip strengthening. You can always include balance and awareness of the ankle position in class. All the other things there on this wonderful map that we've got going, if you have a look at every single thing, like whether it's post-surgery, big injuries happened, dislocated pelvises, really weird biomechanics that we've talked about, they basically all lead down to patellofemoral syndrome or patellofemoral pain. Patellofemoral pain is the number one cause of knee pain in society, in the general public out there. Most people can have another injury, but they have a secondary patellofemoral pain on top of that injury. So for example, I had a lady with a meniscal tear that came in to see me as a physio, and we were working on improving the meniscal injury and getting her back in, but her main pain was actually patellofemoral pain, not meniscal pain. So she had a double thing going on. You've got your original injury that causes swelling and pain and loss of function in the knee, which then leads to patellofemoral pain. So what patellofemoral pain actually is, what are all these things kind of leading towards, is that what I said at the beginning, when your patella is a sesamoid bone, it's completely surrounded by muscle. So the function of your quadriceps directly influences patellofemoral pain. It's a huge part of it. And what normally happens is when you have pain, injury, abnormal biomechanics, any of these things on this chart, you can have what is known as a reflexive inhibition of your VMO muscle. And what that does is it kind of switches off the muscle as a muscle protection or a compensatory pattern that's very, very common following a bout of knee pain. So if someone has had a bit of knee pain, even if they've run the city to surf or whatever run that you've got in your area, and they've got a bit of swelling from having run 10, 14 Ks, and then the next day they've got a bit of pain in the knee. It's not even an injury. It's just the fact that they did a lot of exercise, but there's a bit of swelling there. That can actually lead to a patellofemoral pain because the muscle, the VMO muscle, can be reflexively inhibited for a couple of days, which is a normal thing that happens as a result of load or injury. And then the patella itself will not be pulled towards the inside. It'll get pulled more towards the outside. So the tracking of the patella, where the patella sits in its little groove, will not be centered anymore. It'll be shifted slightly laterally. Now, when it gets, extreme versions of this, I can see people that come into my clinic maybe 3 or 4 weeks afterwards. They put up with pain in the knee for a really long time. They stop exercising because they're worried about hurting themselves. And by the time they get in to see, me as from a physio point of view, their VMO has wasted so much that now it's going to be like a couple of months, 2 or 3 months, trying to recover that strength in the VMO. Whereas if they could do some exercises at home straight away, if you guys can identify somebody that has knee pain, they come up to you in a class or in a session and they say, oh, I've got a bit of a niggle, I did a run on the weekend, whatever. Give them some exercises they can do, which we'll go through, to keep the atrophy of that, the hypertrophy, not the atrophy, keep the hypertrophy of the VMO muscle going so that they don't get weak, they don't waste away, and they can start to, just keep on going with their full function so that when they go back into their training sessions with you, they haven't lost a lot of their strength. So VMO as opposed to BMO, someone put in the chat there. VMO is your vastus medialis oblique. You'll get the notes later, and you'll be able to look back at the anatomy part of it if any of you have missed it. Okay. The VMO is your medial quad muscle, so it's the inside quad muscle. And this is just a picture that I took of a person that came in to see me. When she contracted her patella, so this is the patella here, she contracted her quads, the patella literally moved across to the side like this, like it nearly dislocated out to the side. So you can see here, she's got her quadricep muscle, the vastus lateralis is activated. The patella has literally moved right across to the side, and there is nothing happening here where your medial quad should be, or that VMO muscle should be. And that is what is known as that reflexive inhibition, or that switching off of that muscle. You might come across it if you do more research on it. It's actually known as arthrogenic muscle inhibition, which is a big fat word, but it's just basically your muscle getting switched off. That's what happens. And that's just just one out of many, many examples of people that come through the door with a similar pattern of knee issues. And the way that we address this from perpetuating and becoming a chronic problem is to keep that muscle going in a non-painful way for as long as possible. Now, when you're doing group exercise, very difficult to do. That's something that you need to kind of send them to someone to have some individual sessions to try and keep that muscle going. But you may be able to, like these exercises that I'm showing you, you may be able to instruct them to the class somehow. If you're doing it over 55s, a seated aerobics exercise session, or you know, you just at the end of a class, you can sit them down and try and get them to activate it. You could get them to do a non-weight bearing activation where they're using their muscles to try and just keep that strength as much as possible. Personal training situation where you've got one-on-one or one-on-two or three, you can actually go through these exercises and give them individual instructions to all your personal training, for all the personal training people out there. So some of the exercises that you can do is, you know, this is a picture of just somebody with a band around their foot, and you're actually trying to get the foot, it's like a leg extension type of movement, where you're just helping them to lift their foot up into full range. Because when people have pain in their knee, they do not want to go through full range. So this is the very, very beginnings of how to get this muscle going again and strong again. Another way you can do it is either sitting them close to a wall, or you can put that ball on the ground and push down into it. So you're getting like a static quads contraction where you're activating the VMO and the quadricep muscles together, holding it for a few seconds and then letting it go. So this is what's known as a closed chain exercise, where you're pushing against or can't overcome a particular resistance. You can't push through the wall and move the wall. So it's known as a closed chain type exercise. They have been shown to have very good benefits in improving the strength of that vastus medialis, or the medial quad muscle, early on. So either one of these is a good way to get started with your clients if you've got the luxury of one-on-one training with them. So this is what you want to try and get going to do to try and reduce the amount of that wasting that happens in that VMO muscle, which is the main problem and the main precursor to your patellofemoral pains. Okay, so that's the number one thing to do. But don't forget, like I've said, look above at the hip and the glutes, and look below at the antepronators as well. So let's just spend the last bit of this lecture going through all the things that I would recommend based on my years and years of experience and research about how to prevent or how to rehab your knee pain, which is patellofemoral pain. The main kind of sorry, I just lost track for a sec there. This is just a slide showing exactly what I just said about the imbalance between the medial and the lateral, and the fact that the patella will shift outwards, rub on your femur, and that's what gives you that actual pain. You get like a grinding or rubbing type of sensation on that on the femur. In surgery, I've seen what patellofemoral pain does to the cartilage underneath the patella. So if you take the patella and lift it off and have a look underneath the patella, they have what's known as, the surgeons call it tram tracks, running up and down, like big lines, running up and down the cartilage on the underneath side of the patella, where it has grated on the femur. It sounds terrible, doesn't it? Sorry if you're a bit squeamish out there, but literally that's what's causing you the pain. And the number one thing that you can pick up whether there may be a bit of patellofemoral pain with your clients, I mean, you don't diagnose it or anything, but a lot of them will say that they have pain with greater than 30 degrees of knee bend. So if they go into a squat, that top 30 degrees, they'll have no pain. When they walk, they'll have no pain on the flat. But as soon as they go up and down stairs where they have to bend their knee more than 30 degrees, or when they're going deeper into a squat and they'll feel it after that upper range, they'll start to feel it, that grinding sort of, contact between the patella and the femur. That's the biggest sign of patellofemoral pain. So it's also known as like moviegoer's knee, when everyone gets up from a chair. If you go to a restaurant and have a look around the restaurant, you can pick the people that might have patellofemoral pain by just watching the way they get up out of their chairs at a restaurant. So after sitting for a while and getting up from that deep squat position, that's the classic patellofemoral symptom. So something to look at next time you go to the movies or the restaurant. Now, I want to get into the exercises and focus on the exercises a little bit more than the assessment of it. But this is just a picture of me looking at the patella moving. So basically, I just get someone to sit down, have their leg over a little bit of a towel, and then extend their leg up off the ground. And I'm watching the patella to see how it moves. And if you do that on yourself, you can just do it on yourself now. You know, have your leg out straight in front of you, let your quads relax, activate your quads, and see if your patella shifts out to the side laterally or whether it's straight up and down. Ideally, it should be straight up and down in that groove, but a lot of times it will go out to the side. So this is a seriously basic way of just checking what's happening with the patella tracking. So just do it on yourself before you do it on any of your clients. And the other thing that you could do just to check and see whether your VMO is functioning well and that your, you might have or to check for imbalance between the inside versus the outside quadricep. If you just place both of your hands onto your quad muscle, like in this first picture here Jess is doing, and then relax your quads to start, then activate your quads so you can feel if both the inside and the outside are working, are firing up or contracting. You can get extremely specific where the VMO should be firing slightly before the outside and all this. But you can feel if someone has inhibition where their muscle is switched off, the inside one will not work. And you can look for major differences. Don't worry about timing and specifics of anything. Just look for differences between the inside and the outside. And if you feel a big difference between that inside versus the outside, you can see that it's not working very well, then you need to maybe focus on VMO strengthening in conjunction with your functional quadricep strengthening. So if you see, like Hayden just said there's a clear difference. These are the exercises for you, Hayden. This is what you need to do. And you're looking for big differences in that inside versus outside. Okay, so this, if you want just a super summary of everything that we're going to talk about, what to stretch and what to strengthen, take a shot of this. This is the program that will get you very much specific results from patellofemoral pain. So if you want to rehab from patellofemoral pain, this is what you want to do. Everything on the left-hand side there that says tight, these are all the stretches that you want to try and include in your client's program or in their exercise classes, okay? In the right-hand side here, these are the focuses of strengthening. So you want to bring in exercises that really focus on VMO, adductor strengthening, hip external rotation controls, glute medius strengthening, and ankle stabilizers, which I've spoken. So that's the real summary of everything that we're talking about today in regards to patellofemoral pain rehab. So we'll just quickly go through the ways to stretch. Ways to stretch ITB or the lateral structures are, these sort of ITB stretches. This one, if someone has a dislocating patella, do not do this one. You've got to be very careful and pick your client when it comes to this stretch. So it's not my favorite stretch, but a lot of people find this one very good at getting a good stretch down through the ITB. And with this one, it's much easier to do the standing one. You take the leg that you want to stretch behind and then push your hips out to the side so that you're stretching the leg that is behind. That's your ITB stretch that I know. Now, holding it again, 20, 30 seconds, there's a lot of argument. I'm not going to talk about like stretching it at this stage of the game, but that is one way to try and improve a bit of mobility or reduce that tightness in those lateral structures. You could do a bit of a foam roller scenario, a bit of a release with the foam roller. And I find that you should be doing right up the top of the hip. If you're going to do a release, try and encourage a bit of TFL, work on that as well, up the very, very top. They're both internal rotators and will increase that valgus knee drop and increase the risk of patellofemoral pain. So working with the roller, giving a massage effect on the very top of the hip is highly recommended. And then also right down the bottom on the lateral knee structures, the lateral capsule, and right down the very bottom is also a good way to try and address the ITB, rather than do a lot of work on that middle bit, which is super hard to, I mean, it's painful as hell. Your client will probably cry and punch you, and it's not as effective as working the upper and the lower. But it's more just a massage effect and just trying to help with the tight structures than having any permanent sort of release onto that structure. Okay, so let's get the VMO going. I've already spoken about these sorts of things, which is how to improve your VMO function and get the VMO activated. In regards to exercise-wise, when you're doing quads, you should be thinking about a focus on adductors as well as quad strength with a focus on abductors, because both of those tend to work. They work for different people in different ways, but having that lateral sort of pull helps with that VMO activation, rather than just keeping your squats parallel and working quads in that parallel. If you add a little bit of a band pull to the sides, or squeezing on a pillow to go, or the Pilates ball to go inwards, that can help to fire up that the VMO. So I've just listed a couple of things down there to remind you of some of the cues that you would give to your clients, like lifting your arches, making sure the glutes are activated at the same time as strengthening those VMO muscles. So what we always do with our Active Rehab Solutions workshops that we run, our online workshops and face-to-face, is we spend a little bit of time going through the background and anatomy, but now we're going through all of our exercise progressions. So it's all about, rehab is so much about progressing the strengthening, slowly building up the strengthening, so that people don't, injure themselves again, and they don't skip all of that functional sort of strengthening and go right back into sport without really addressing the weaknesses that they have, which caused the injury in the first place. So in this slide, this is basically the extreme beginnings, the very, very beginnings of getting that muscle working again, getting people understanding where that VMO muscle or the inside quad muscle is and how to build the strength of the quadriceps very, very early on. And you can see there in the first picture, it's just activating, just contracting with a bit of a band pull outways. So it's getting a bit of inside thigh adductor strength in addition to your quadricep activation. The second one, this is open chain, where the foot is up off the ground. You can roll up a towel, put it under the knee, and get them to do mini leg extensions. This is like something that physios would give someone in a hospital that's just had surgery. I mean, this is seriously beginner stuff, right? The end range quads control is a good one that you can give to people for homework. They can do this watching the telly, sitting on the couch. They can, instead of putting their foot on the wall, they could put their foot on the edge of the couch, or they could put their foot on the ground. And they could just practice doing this while they're watching their Netflix in the nighttime. And that way it just helps to keep that the muscle strength going. Then if you wanted to progress them a little bit further, you could do some standing or some sitting things I'll show you in a sec, but the standing things are actually very good, especially with the legs almost straight. You've got to remember that the first 30 degrees of knee bend, they're in no pain. So they can do a lot of strengthening in that upper range, build up the strength in the upper range before bringing in a deeper and deeper squat as they progress and improve. So if you look at the first one, you can put a big fit ball behind the knee. This is the knee that you're working, the back leg here, and you can straighten the leg out against the ball. The ball's going to be pushing the leg back into flexion, the knee back into flexion, and you want to try and straighten your leg out against that ball there. You can add a band around the knees to add more resistance, put a band around and then straighten out. Or if you don't have a wall for everybody, everyone in class could do this sort of situation. If you're having a knee strength class day or something like that, you could focus on it. Or if you just have the bands, you could just use the band. You don't need to have the ball there in addition. So I've just given you a couple of other ones that are lovely closed chain exercises. I mean, you can focus on every part of the body. It's balance, it's core, it's glute activation, foot positioning, but also knee strength at the same time. It's a very good functional rehab exercise. You can also do, if someone is uncomfortable in that lunge position and they're a bit unstable or they're a little bit older and their balance isn't as good, you can get them to go either straight against a wall. Now, this squat here is definitely more than 30 degrees. So you want to find them in that upper range. I've got listed out there the upper ranges initially. So make sure you're only working in that upper, that mini, I call it the mini squat, you know, or mini static squat against the wall. You could have just back against the wall. You could have a ball against the wall. That makes it a little bit more difficult, but it makes it from a balance point of view. But you can make it, it's easier to move up and down if you have a ball there to roll against. And then, like I said before, to help encourage the inner muscles to work, you could do a little ball in between the knees, a medicine ball in between the knees, or a rolled up towel, pillow, whatever you got handy. Or some people work really well when they've got a band around the knees, like a crab walk, you know, pushing outwards into abduction, and then doing little squats with the abduction, or a static squat with abduction. So these are ways to strengthen and keep people moving and keep people exercising whilst they're going through their knee pain. They don't have to stop because they've got knee pain. You could literally have, like in a program situation, you know, all your core work, you could do all your upper body strengthening, you could do all your plank work with your legs straight. You know, they don't have knee pain when their legs are straight. You could do all your standing balance with legs straight. And then you could add in a little bit of knee rehab to just focus on that knee and make it more specific for your client. Okay, that's how you keep people going. Don't lose your clients because they've got a bit of knee pain. Okay, and then, you know, as you're progressing on, you can start to bring in a bit of stairs. I always like to use the step platform sort of thing, just a very, like a half a step. That is less than 30 degrees, usually doesn't give them any pain, and really helps with the strengthening of the quads and the VMO and balance, brings in everything all together. So this is just progressing it a little bit further. You can either do little lunges, or you can do the step ups or the step downs. You know, these are all exercises that we're familiar with, but if you just modify it that little bit, then people just, they really do get uplifted, like they feel like they're actually making progress, that they'll get through this injury and be able to keep exercising and achieve their goals. So these are some of the other exercises I would recommend. And then, of course, as always, you don't just stop there. You want them to progress back into their sport-specific or goal-specific things. I mean, if it's an 80-year-old that just wants to be able to get up out of her soft recliner chair, that's her goal in life, then you're not going to do ladder agility drills with I'd like to see that with your 80-year-old. You'll be doing things that are more specific to her, like going lower into the benches, finding benches that are lower and lower, and progressing them that way. So these are examples of the dynamic. This stuff I know you all do very, very well and are very familiar with. It's the ones previously leading up to that is the modifying and reducing, regressing, I suppose, the exercises is always the hardest thing. So, this is really just a webinar to show you, this is one thing that we cover as part of our knee active rehab, which is our online course workshop that we run for personal trainers, for exercise physiologists, etc. And I mean, we talk about ACL, PCL rehab, we talk about MCL rehab, we talk about all sorts of things, calf strains, all the exercise progressions for your muscles, hamstrings, adductors. It's all included in these workshops, and every workshop that we do focuses on the specific muscles. So it's not about diagnosing. It's not about, you know, from a physio point of view, you know, my background with doing the group exercise instruction and personal training before I became a physio, it's all about those exercises. You know, that's what's important, keeping those clients exercising and keeping them achieving their goals for as long as possible. That's, you know, that is what it's all about. So for you guys, all you lovely, wonderful people that have joined in today and made this, you know, worth our while, and it's fabulous to be able to reach out to all of you and be included in this webinar today. If you use the code on our website, Oz50 for OzActive, supporting us today, you can, off any of our online workshops, you can get $50 off. So huge, big saving if you wanted to get some online workshops for CECs. And the workshops will be valid at least for another 1 to 2 years. So even if you don't want to do it this year, but want to do it another year, I would take advantage if you want to. So this is an exclusive deal for you guys. Okay, I think that's basically everything there. And I think Luke, okay, there we go. Luke, I'll pass it back to you. Thank you so much for having me. That was wonderful. I enjoyed it very much.
Yeah, thank you, Merrin. That was terrific. I could see the comments flooding through with praise as well, which is great to see. So I'll pass all that on to you afterwards today. Thank you everyone for attending as well. We'll run through a quick few questions if you've got time, Merrin, and for anyone that's able to stick around. Understand that you'd only say an hour today, guys. If you have to go, that's fine as well. But for those that can stick around, we'll just go through a few quick questions. So from Lena, we just got asked, where did you do your Pilates training, Merrin?
My Pilates training?
Yeah.
I did my Pilates training before there was even Pilates training people around. So I worked in a Pilates studio that had a couple of instructors who were instrumental with the APMA. So it is more an APMA, which is the Australian Pilates method, I think, or Australasia or something like that, the APMA. I've been in contact with also the Polestar Pilates. We've had a number of instructors come and go with that have been Polestar trained as well. So there's Polestar Pilates is another highly recommended group if that's what you're looking for, like to be trained in the Pilates. But a lot of my Pilates training has come from what's called DMA, clinical Pilates, which is a physio run Pilates based for movement direction biases for injury. So it's very specific for injury Pilates, so to speak, with the guy in Melbourne. I can't remember his name off the top of my head, but anyway, he. So I've done like a number of Pilates instructor base courses. This was like 25 years ago, and then since then have done all the physio trained Pilates, the clinical Pilates training.
Yeah, fantastic.
Yeah.
Thank you for that, Leah. So we have a question from Susan, who says that her client pushes on the ball rather than using it to keep the knees spaced. Should she use a stronger ball or discontinue with the ball altogether?
You want to be able to straighten the knee if that's what we're looking at. So you want to be able to have the ball at a level that it's not too hard, so that the knee stays bent, because the VMO actually gets recruited the most in that last 10 degrees of extension, so that end range quads control. So if you have a ball that's so pumped up that you can't actually straighten out the knee, you don't want that to happen, but just soften it a little bit so that you can actually push against the ball and straighten the knee, hold it for a few seconds, and then relax back off.
Yeah, fantastic.
Yeah.
Question from Joe. It says tibial torsion after TKR. What is the best option to assist with this technique?
Okay, after TKR, TKR is a total knee replacement. So when people have their knees replaced, I've seen it sometimes they're not quite the alignment that they were when they went in. So sometimes it's a structural thing. And like I was saying with the, you know, the bow legs or the knock knees, if they have a structural sort of tibia vera as a result of that knee replacement, like I don't know if it was there before or not, but if it's there with the knee replacement, it's usually something that's going to stay there. You're not going to resolve it. And a lot of the time, and I do cover this in my knee workshop actually, is that people will avoid bending the knee and they turn their foot out. So it's like a 20 years in the making, that tibia vera with total knee replacement, because of knee arthritis that's gone on in the knee. So, you know, again, there's no you know, specific thing that you would do. With the total knee replacement, you have reduced amount of mobility in that knee hugely compared to a normal sort of functioning knee. So you would have to limit the range of motion that you do when it comes to quad strengthening, calf rises, you know, glute strengthening, all of the balance things. You're going to have a very reduced amount of range of motion. That's probably the biggest thing that you'll find the difference with total knee replacement versus a normal knee. Yeah.
We've got a question from Helen, who just asked, do you find any difference in doing the exercises barefoot or in minimal shoes, as opposed to regular cushion trainers or runners?
Yeah. I do a lot of my exercises without the shoes on, because I really want to have a look at what's happening with that pronation and that ankle control, because that is such a big part of it. So the only time I would so orthotics sort of comes into this as well. So if you do shoes, if you have shoes and orthotics, that's going to give you the most amount of control of the ankle, so you can focus on knees or hips. If you want to make it harder and challenge the person, the more you go into minimal or barefoot or socks, you know, the non-slip socks, that's actually a better option, because it brings in that component of being able to strengthen and control ankle as well as the knee, as well as the hips. So it makes it a bigger challenge. So I would recommend it, but you have to pick your client. You're not going to do it on older people or people starting out. This is like a progression to make it a bit harder.
Right, next question. Thank you everyone for throwing them in as well. So Sandra asked, is there a deal for all the workshops, or like a pack for the workshops that you mentioned earlier as well?
Okay, there are some bundle deals that we do. If you're wanting to purchase like a hip online, knee online, I'm still working on the ankle online, but the hip and the knee online together as a bundle, for example, the best thing to do is email us and we can give you some discounts. So if you wanted to buy multiple ones for yourself, or if you're wanting to purchase, you know, we had someone buy 7 knee courses the other day for all of their personal trainers at their place. So if you wanted to buy multiple of the same one, email us. Our email is, I don't know if it's there, but it's learn. So learn, L-E-R-A-N. Maybe you could just type it in the chat there,
yep.
Luke.
Yeah, I'm just trying to.
Yeah, there we are. Luke, there we are. Luke's got it there. learn@activeanatomy.com. And that way, if you can just reach out, we'll definitely be putting in some discounts for you as a special today. So thanks for that. That'd be great.
Yeah, perfect. And everyone will be getting in a copy of the slides from today as well, which will have more info about those that slide up before as well. So Sarah popped a question and saying she's got a number of clients who complain about crunchy knees that are not associated with any pain. Do you have an insight on that at all?
Crunchy knees, they sound revolting more than anything. The thing to think about crunchy knees is it's crunching for a reason. So there is either, you know, capsule or inside the knee or cartilage under the patella or something that's over the years is causing that crunch, that crepitus. It's called crepitus in the knee when people squat down and you can hear it sort of crunching all around. But if it's associated with no pain at all, no one seems to care about it. Like I've asked surgeons about it in the past, I've asked multiple other people, and no one seems to care about it. Continue on with exercising. but they are at risk of getting patellofemoral pain. So you want to, like all the things that we covered today, you definitely want to include that as part of their prevention. So any crunchy knee people, use it as a prevention, use these exercises to prevent them from getting pain. But if it's a crunch with pain, that means that cartilage could be getting damaged and you really need to either refer on or get a diagnosis or get it looked at, because it will perpetuate a chronic issue, especially if there's swelling associated with it as well, which can really start that whole patellofemoral pain problem, inhibition problem happening in the first place. So a bit of crunch in the knee when you go up and down the stairs is no one seems to care about, but do your preventative work anyway. Yeah.
I can see a bunch of people may have to leave shortly, so we might make this the last question. And of course, if anyone does want any more info about or does have any more questions for Merrin, the email is there for Active Anatomy as well. So the learn at activeanatomy.com. So yeah, please reach out to them if you do have any other questions. So Neha asked, is there a way to recover the cartilage loss on the medial patella if the focal loss is less than 10 millimeters?
Very good question. I don't think there is. There's a lot of new research that's out and new techniques that's out for cartilage recovery on non-weight bearing parts of the knee, which is what the patella is. It's a non-weight bearing part. So it's not meniscus, not on the tibial plateau, it's on the back of the patella. They're looking into all sorts of cartilage replacements. In the past, they've done, lots of chondroitin and glucosamine, which is then been, told that it doesn't have any effect in regenerating the cartilage. From a surgical point of view, they try and debride the cartilage to try and create a trauma process and then a healing process following that. So it's out for debate still. I think 10% is small numbers, but it's a long road. And even when people just have a tear in their cartilage that I've rehabbed over years and years, like many people, it takes months and months for it to settle down and get better. So the cartilage on the back of the patella or the cartilage on the femoral condyles in the non-weight bearing position are probably the hardest ones to come back from. So it's still out there. I don't have all the answers for that one. That's a very specific one that you would have to look at all the evidence as to what works and what doesn't work. It's hard. It's very hard.
Yeah,
but all I could say is just give yourselves months and months and months and focus on a lot of strengthening, because it is a chronic problem.
Yeah, thank you for that, Neha. That's terrific. I don't think we'll be able to get to too many more questions, so we might wrap it up there. Did you have any closing words at all, Merrin?
Nothing. Just thank you again for having me, Luke, and for everyone joining in and supporting us. With all the COVID excitement and the flood excitement and everything else that's gone on lately, it's so nice to be able to get back out and reach and do face-to-face, even if it is over Zoom. So just like I said, just reach out to us if you want to have any discounts or any questions about how to purchase. Our website is Active Rehab Solutions as opposed to Active Anatomy. We changed our name a few years back, but our email is still learn@activeanatomy.com. So they're the best ways to contact us. But thank you again, everybody, and thanks to Luke. Thank you.
No worries, thank you. If anyone has any confusions about the name or email, just reach out to Oz Active. We'll be able to pass it on as well. All right, thank you guys. See you later.